Hello, this is Allison Littleford, a BS into DMP student, and I'm going to be presenting a case study that I did in the ICU while following a nurse practitioner that works for the cardiologist at Jane Phillips. The patient I'm going to tell you about is an 18-year-old Caucasian male patient that presented to the ER. He had came from his pediatrician's office for a follow-up appointment where he was initially diagnosed with cellulitis. He came to the ER at Bartlesville with complaints of bilateral lower leg edema, worse on the left side than the right. He had increased redness and pain and swelling, tenderness to the touch, painful ambulation to where he was barely able to ambulate from the wheelchair to the bed on arrival to the ER. He had shortness of breath, hypoxemia, and tachycardia. This young man is a senior in high school. He works part-time at a farm store. He's active in his high school marching band, which they were prepping for competition. He'd been practicing at least 1 to 2 hours daily, sometimes more. The symptoms started 3 to 4 days ago. He stated he was seen by his pediatrician 3 days ago. Initially, his pediatrician diagnosed him with cellulitis and started him on antibiotics, Keflex. The characteristics of the symptoms were progressively worsening pain in the lower extremities, unbearable today. He wasn't able to put his legs down, get up and walk. The pain was tightness, burning, constant pain, and like I said, it was worse with ambulation and palpation with us assessing him. He had shortness of breath that started this morning and was progressively getting worse this AM, which prompted him to go back to his pediatrician and then which was sent to the ER. He arose to the ER again by private vehicle via oxygen via wheelchair. His oxygen saturation on arrival was 88% with a pulse in the 120s. An EKG in the ER did show that was sinus tachycardia. So I initially included his birth history because he had turned 18 2 days prior to his admission. He's a term infant with no chronic disease. He was overweight. His BMI is 30. No known drug allergies. He did not take any daily medications. He denied ever being a smoker, denied using street drugs, denied ever drinking alcohol. He also denied a sedentary lifestyle, as I reviewed earlier. He was in the marching band 1 to 2 hours, 5 days a week, more on the weeks of his competitions. He did work part-time at a feed store where he was lifting heavy equipment and moving around, denied any recent travel, no recent surgeries, no injuries, no traumas, and no long periods of sedentary lifestyle where he was just sitting or vegging out watching TV or doing video games. He's a pretty active young man. His family history was complicated by his brother's death of brain cancer. He had been seen at our facility for his initial head CT for symptoms related to what ended up being this brain cancer. He was never diagnosed here or had any biopsies. He was sent to Tulsa and Oklahoma City, so we didn't have an exact diagnosis of the brain cancer the time that I saw him. He had died less than 6 months after the diagnosis, approximately 7 months ago. So that was certainly a concern for the patient and then his parents at the bedside who were gravely concerned that his symptoms were possibly attributed to cancer. His paternal grandmother had unknown clotting disorder, and she had died of some type of cardiovascular disease. The family was not very good historians or very accurate with their past medical history. She was treated with Coumadin. Mom and dad of the patient, so they denied any medical history, no blood pressure problems. They also both were about a pack a day smokers, which the patient himself had been exposed to this pack history from his parents' secondhand exposure. But both parents actually quit smoking when the brother was diagnosed with brain cancer. So both parents stated they had no history, but their follow-up with primary care and just routine screening was pretty poor. Neither one of them had checked a recent blood pressure, but neither one of them had a clotting disorder or had ever been told that they had a clotting disorder, and both denied any excessive bruising or any problems with that as far as they knew. So I'll just hit on kind of the highlights. He hadn't had any weight loss or gain, but he had had fatigue for the past 3 to 4 days. He hadn't had vision changes. As far as dizziness, that had just started that morning when he started having the shortness of breath and tachycardia. He was positive for chest pain on exertion. Once he got to the ER, he did complain of that, palpitations, and then the main concern for him was his lower leg pain, which was bilateral, worse on the left side. He had no cough, and he hadn't been coughing up any blood. He did have shortness of breath on arrival, no nausea, vomiting, denied, numbness, tingling, anxiety, or depression. The only complaints of pain were more in his muscles and in his lower extremities, and then the chest pain that was new since this morning. And then he did have that edema, warmth, and bilateral edema in the lower extremities. Okay, so on arrival, he was afebrile, pulse was 120s, blood pressure was 130s over 70s. He was hemodynamically stable. As mentioned before, he was overweight with a BMI of 30. O2 on room air was 88%, which we placed him on 3 liters of nasal cannula, and he was mid 90s, 94, 95. Any exertion, he was increased shortness of breath and workload of breathing. Head, ears, nose, throat, everything there was normal. Cardiovascular, he was sinus tachycardia with this, again, edema in the lower extremity, severe on the left. Right was slightly less. Pulses were palpable on the right, weak. With Doppler, they sounded strong. Doppler on the left was very weak, and we weren't able to palpate those. Lung sounds were clear throughout. Chest x-ray was negative. Abdomen was unremarkable. Musculoskeletal, he did have full range of motion. Obviously, the pain and tenderness with palpation, as described before, and then this redness, delayed cap refill, just severe edema on that left side and pain with any palpation, and then, of course, the decreased pulse on the left side. Eyes and neuro were normal. Now, this young man had a CBC, a Chem 14, PT and INR, UA, a UDS, and bilateral lower extremity venous ultrasound, and a CT angiography, pulmonary embolism protocol, and then an abdomen, pelvis, and a CT head without contrast. Now, he had more testing done with his brother's history of cancer than a typical patient that presented with the symptoms had. But because of this history and family concerns, they decided to go ahead and do a full scan to make sure there was no cancer that could have possibly been hereditary or had a more likely cause for this brother, since they didn't know the name or have a history of his brother's cancer. Okay, so this young man's CBC, Chem 14, urine analysis, and urine drug screen were all unremarkable. Nothing to indicate a cause for a clot or any of these symptoms. His ultrasound of the lower left extremity had acute extensive thrombus with near total occlusion. The right side showed evidence of a recent clot, and then the CTA revealed a small saddle PE with segmental and subsegmental defect filling to the bilateral lower lobes. So he had this large clot that had likely traveled from the right side, and then he had this left sided DVT that was still present. So he was obviously a sick young man. His head CT was within normal limits. There was no significant findings, and the CT of his abdomen pelvis didn't show anything abnormal either. So he was admitted to the CCU. So he was admitted to the ICU and started on the high dose heparin bolus and drip protocol for PE, and went to the unit where they followed the appropriate lab protocol with our heparin drips. He also was prepped for surgery in the morning, where he was going to go to the cath lab for an IVC filter and a ECOS procedure. Now, I compared what was recommended on Up to Date in a unprovoked blood clot and placement of an IVC filter. He met the requirements because we didn't know the cause. He had such a large clot load that we were able to see on ultrasound in his lower extremities, and then the saddle PE with defect filling already, that they felt it was necessary to go ahead and place the IVC filter. Is a really interesting case for me and our whole hospital because this was the first instance where we were able to use the EKOS, which is the Ecosonic Endovascular System. Some of you probably are really familiar with it. I had never seen it before, and I haven't spent a lot of time on the cardiac floor, so I thought it was fascinating to read more, watch some videos, and get to actually follow this patient. He had a EKOS placed for his DVT. They can use it for a PE or DVT, and the ultrasound goes to the site of the clot, which he had a very large clot, and then they're able to drip TPA as the physician orders into the actual clot, and then the ultrasound helps break up these clots. So he went in and had that filter placed, and then the eco catheter placed, and they used TPA as their clot buster drug. I wouldn't be able to tell you the rates without looking through his chart again, but I got to go in and see the drip infusing and then with the coolant, and it was kind of interesting because we were still trying to palpate or use the Doppler, which you have to put the machine on standby because it'll interfere. You can't Doppler pulses. So that's just one thing that, at the bedside, getting to see him after surgery, that I thought was interesting. I also reviewed studies to compare what the effectiveness of EKOS versus traditional thrombectomy approaches that our facility had used in the past, and I found that there's studies that are varying, and there's a lot of back and forth about what the most effective, because there are some studies that show EKOS has a higher mortality rate, but the study that I looked at was for PEs, and then another independent review of DVT treatment, and there were no deaths in the DVT treatment, and they had shorter hospital stays and less post-hospital complications. So the studies that I ended up reading about EKOS were pretty favorable for this being the best option for our patients. So this 18-year-old patient was the first one to have an EKOS catheter, and it was for that left large DVT, which I didn't get to actually round on him after that first day and having the EKOS catheter placed, but he did have really good results. I know everybody was really pleased with the outcome. I just didn't get to see him following that. I wanted to discuss the nurse practitioner role in the management of this patient's case. Um, Something I got to actively participate in was discussing provoked and unprovoked DVT with the mom and dad and patient, and letting them know, as far as we can tell, this is unprovoked until proven otherwise. He didn't meet any of the risk factors, and his lab work was normal. And we wouldn't be able to send him to a hematologist until he had been on the anticoagulation for at least 6 months, and he'd have to go off of that for an extended period of time to have testing done to assess for a clotting disorder. So in that case, I got to discuss with the family what his risk factors were, being on an anticoagulant, and what the risks were if he wasn't on one. And ultimately, we were able to settle on Xarelto as the anticoagulant of choice, because after the loading dose period of him being on this twice a day dose, then he could go to the once a daily, which was important to the patient, so he wouldn't have as much to remember. Of course, when you're talking about being on long-term anticoagulant with an 18-year-old boy, there's a lot of risks you have to discuss and a lot of education. So that was one way that I felt like I got to actively participate in and make decisions with the family and patient with my preceptor. It was a very fascinating case where I got to learn a lot about a new procedure and protocol in our facility, and get to see it firsthand and assess the patient and be really involved and talk with the rep. So I thought that was all very interesting. Again, I reviewed in up to date in a few case studies on EKOS versus a traditional approach of thrombectomy, and the outcomes seemed very good for the EKOS. I'm really excited to learn more about it in our facility. Appreciate your time.